Hello everyone, I am Dr. Nirmala Devi. Today we are going to discuss general pharmacology. In that, we are going to study pharmacokinetics, and in it we will discuss in detail absorption part. Here we are going to study basic concepts related to pharmacokinetics, absorption and its mechanism, routes of drug administration, factors affecting absorption, bioequivalence, bioavailability, and factors affecting bioavailability. So let's begin. Pharmacology is a science where we study principles of interaction between drug and body. Pharmacology is studied under two parts, pharmacokinetics and pharmacodynamics. In order to understand and control the therapeutic action of drug in the body, it is very important to know some of the basic aspects known as absorption, distribution, metabolism, excretion. In one line, we can say that pharmacokinetics is the aspect where we study what the body does to the drug. It is studied under absorption, distribution, metabolism, and excretion of the drug. Here in this diagram, we can see that pharmacokinetics involve absorption. After any drug is administered through oral route, it is absorbed and then it is distributed and it is metabolized through various routes. And if the drug is given directly into the systemic circulation through intravenous route or any other route, then the lengthy path of absorption through GIT is shortened. Now, which drug is available for absorption and distribution? Distribution of the drug at the site of action is desired, and only the drug which is free, it means which is not bound with any site or any protein structure or any fat deposit, is available to be distributed. And then when it enters into the then it is getting metabolized through liver and other metabolizing sites for biotransformation and before elimination. Now, what is absorption of drug? Absorption of drug is the movement of drug in its site of administration into the central compartment and to other parts. So, in absorption, we study the movement of drug and the extent it is absorbed from the GIT. Mechanisms by which drug cross membranes depends on molecular weight of the drug, chemical stability of the drug, lipid solubility, degree of ionization, and pharmaceutical formulation factors of the drug. Let's discuss cell membranes. To understand the process of absorption, we must understand the structure of cell membranes. So everybody knows the cell membranes is a lipid bilayer. At two sides, we are seeing hydrophilic heads below and upwards, and in between these two hydrophilic heads, we could see hydrophobic tail. Individual lipid molecules in the bilayer can move laterally and organize themselves with cholesterol, example sphingolipids, endowing the membrane with fluidity, flexibility, organization, electrical resistance, and relative impermeability to highly polar molecules. Membrane proteins embedded in the bilayer serves as receptors, ion channels, and transporters to transduce electrical or chemical signaling pathways. Many of these proteins are target for drugs. These proteins may be associated with caveolin and sequestered within caveolae. They may be excluded from caveolae or they may be organized in signaling domains rich in cholesterol and sphingolipids, not containing caveolin or other scaffolding proteins, that is lipid rafts. So this is the cell membrane. Lipid soluble substances are easily crossing the membrane, but water soluble always require some permeability factors like pore channels or through filtration. So these are the different mechanisms of drug absorption. Most of the drug is absorbed through passive transfer. in which we study passive diffusion, pore transport, and filtration. And if drug is not transported easily or passively, then a specialized transport mechanism is there, which is studied under active transport, facilitated diffusion, ionic diffusion, ion pair transport, endocytosis, and exocytosis. Cell membranes are relatively permeable to water either by diffusion or by bulk flow or bulk flux resulting from hydrostatic or osmotic differences, which is known as solvent drag across the membrane. Bulk flow of water can also carry along with it smaller drug molecules or solutes, which is generally less than 200 daltons. Examples like endogenous substances, urea, sugar. This type of transport is called pore transport or filtration. The pore size differs in different tissues. Pores in the capillaries and renal glomeruli are largest, which is 50 to 100 nanometer diameter. Now, pore transport is very important in case of renal excretion, removal of drugs from CSF, and entry of drug into the layer. Generally, transmembrane movement of drug is limited to unbound drug only. Drugs which has already formed the protein complexes with the proteins, they are not absorbed. They are absorbed poorly, but they remain in a active reservoir of drug that can influence both therapeutic as well as unwanted drug effects. Paracellular passage through intercellular gaps is sufficiently large that transfer across capillary endothelium. Such membrane passage is an important factor in the filtration across the glomerulus in the kidney. Paracellular passage is limited in blood-brain barrier because capillaries of the central nervous system and a variety of epithelial tissues have tight junctions. We can understand this through this diagram. You can see this is a diagram of endothelial cells uh, in a usual capillary. And here we can see brain capillary. Here the intercellular pores are not present, but in this case, pore transport is possible. The basement membrane is there, which is not present in the usual capillary. And after that, the glial cells are tightly and or compactly packed so that lipid soluble molecules only can pass through it, but any drug through the filtration or pore transport is not possible. So in A diagram, we can see usual capillary has large intercellular pores through which large lipid insoluble molecules can also diffuse. But in case of B, capillary constituting blood-brain or blood CSF barrier, tight junctions between capillary endothelial cells and investment of glial processes or choroidal epithelium do not allow passage of non-lipid soluble molecules. Now we will discuss each mechanism one by one. Passive membrane transport. It is not requiring energy for transport of substances across lipid bilayer. Such transfer is directly proportional to the magnitude of concentration gradient across the membrane to the lipid water partition coefficient of the drug. In this case, the medium and surface area, blood flow, and lipid solubility are important parameters. Weak electrolytes and influence of pH. Most of the drugs are either weak acids or weak bases, and they are present in solution as lipid soluble, diffusible, non-ionized form, and the relatively lipid insoluble, non-diffusible ionized species. Therefore, the transmembrane distribution of a weak electrolyte is determined by its pKa. What is pKa? It is a pH at which 50% of the drug is in its ionized form, and the pH gradient across the membrane. This can be understood by Henderson-Hasselbalch equation, which is a log ratio of protonated form and unprotonated form is equal to pKa minus pH. This equation relates the pH of the medium around the drug and the drug's acid dissociation constant pKa to the ratio of protonated and unprotonated forms. At steady state, an acidic drug will accumulate on the more basic side of the membrane and a basic drug on the more acidic side of the membrane. And this phenomena is termed as trapping. So we can understand this concept better way through this diagram. pKa is the negative log of acidic dissociation constant of weak electrolytes. If the concentration of ionized drug is equal to concentration of unionized drug, then their ratio is 1. Since log of 1 is 0 under this condition, then pKa becomes equal to pH. So this is a condition where 50% drugs uh, becomes ionized. 50% of the drug becomes ionized. So you can see here influence of pH on the distribution of a weak acid between plasma and gastric juice separated by a lipid barrier. So here in diagram A, the dissociation of a weak acid whose pK is 4.4 and B shows the dissociation of weak acids in plasma where pH is 7.4 and gastric acid pH is 1.4. The uncharged from HA equilibrates across the membrane and blue numbers in brackets show relative concentration of HA and HA minus. Passive diffusion is best described by Fick's first law of diffusion. Passive diffusion, as you know, is also known as non-ionic diffusion and is responsible for absorption of almost 90% of the drugs. It is energy independent and non-saturable, but to some extent depends on the square root of the molecular size of the drug. The molecular size of the drug for passive diffusion should be under 100 to 400 daltons. So what is Fick's law? Here dq by dt is equal to dA kmw multiplied by concentration difference CGIT minus Cp whole divided by H. dq by dt is rate of diffusion, d is diffusion coefficient of the drug through membrane, A is absorption surface area, kmw is partition coefficient of the drug between the lipoidal membrane and the aqueous GI fluids, H is thickness of the absorbing membrane, and CGIT minus Cp is the difference in the concentration of drug in GIT and in blood plasma. Now, what is filtration? Drug through the pores of cell membrane, epidermis or mucous membranes of the GIT, the capillary endothelium, glomerular membrane occurs with the flow of water depending on the hydrostatic and osmotic pressure. Molecules, endogenous water molecules, urea, glucose, and some ions use filtration method. Then carrier-mediated transport. It is of two types, active transport, facilitated transport. So carrier mediated transport is possible with the help of carriers, carrier transport proteins. They can be enzymes, they can be ion channels, they can be pores, or they can be some particles which are going inside and outside of the uh, cell membrane. Large particles like bacteria or nanoparticles, they can be phagocytosized. Small particles like proteins, viruses, lipoproteins, they can be cytosed. Active transport is characterized by a direct recruitment of energy, movement against electrochemical gradient, saturability, selectivity, and competitive inhibition by co-transported compounds. Sodium-potassium ATPase is an important example of an active transport mechanism that is a therapeutic target of digoxin in the treatment of heart failure. Secondary active transport uses the electrochemical energy stored in a gradient to move another molecule against a concentration gradient. Example, the sodium-calcium ion exchange proteins uses the energy stored in the sodium gradient established by sodium-potassium ATPase mechanism to export cytosolic calcium and maintain it at low basal level, that is almost equivalent to 100 nanomole in most cells. Similarly, the sodium-dependent glucose transporter SGLT1 and SGLT2 move glucose across membranes of GI epithelium and renal tubules by coupling glucose transport to downhill sodium flux. Iron absorption and uptake of levodopa by brain. These are the some other examples. So in this diagram, we understand that passive transport do not require energy. Active transport require energy in the form of ATP or exchange from other ionic transport. Diffusion and facilitated diffusion both are passive way of transportation. Difference is in facilitated we need a medium which can be a transporter. In active transport, energy is the uh, process. Now, what is facilitated diffusion? Facilitated diffusion is a carrier-mediated transport process in which there is no input of energy and therefore there is enhanced movement of water-soluble endogenous nutrients like monosaccharides, amino acids, and vitamins down a chemical gradients. As in the permeation of glucose across a muscle cell membrane mediated by insulin-sensitive glucose transporter GLUT4. This is one example. Such mechanisms may be highly selective for a specific conformational structure of a drug and its affinity. For example, anti-cancer drug 5-fluorouracil, 5-bromouracil in cancer works through this mechanism. They act as a false nutrient for transport. In other cases, they function as exporters, creating a barrier to prevent the intracellular accumulation of potential toxic substances. Pharmacologically important transporters may mediate either drug uptake or efflux and often facilitate vectorial transport across polarized cell. An important efflux transporter is the P-glycoprotein, which is encoded by multi-drug resistant 1-MDR1 gene. P-glycoprotein localized in the enterocyte limits the oral absorption of transported drugs because it exports compounds back into the lumen of the GIT subsequently to their absorption by passive diffusion. P-glycoprotein can also confer resistance to some cancer chemotherapeutic agents. So in this diagram, we can see that facilitated diffusion is carrier mediator. Here, for example, SLC is a carrier which binds and moves the poorly diffusible substrate along its concentration gradient, high to low, and does not require energy. This is actively transported substrate ABC. So ABC primary active transport, the carrier ABC derives energy directly by hydrolyzing ATP to ADP and moves the substrate against its concentrated gradient against concentration gradient, which is low to high. Then here we can see that this is a active transport, substrate A, substrate B in C diagram. This phenomena is called as symport. Here transporter is a symport. The carrier moves the substrate A against its concentrated gradient by utilizing energy from downhill movement of another substrate B in the same direction. And in picture D, we can see it is an antipode where the carrier moves the substrate A against its concentration gradient and is energized by the downhill movement of another substrate B in the opposite direction. So in symport or in antipode, both these transporters they use downhill energy by another substrate, but movement is there against the concentration gradient. In symport, both substrate A and B travel in the same direction, and in antipode, substrate A and substrate B travel in the opposite direction. Endocytosis and exocytosis are other mechanisms. The movement of macromolecules such as proteins or polysaccharides into are engulfed or exited out of the cell, and it's called bulk transport. There are two types of bulk transport, exocytosis and endocytosis, and both require the expenditure of energy. So endocytosis and exocytosis comes under active transport processes. In exocytosis, materials are exported out of the cell via secretory vesicles, and in endocytosis, the process by which materials move inside the cell. There are three types of endocytosis: pinocytosis, phagocytosis, and active phagocytosis. Now we will study different factors of drugs across different physicochemical factors which is responsible for absorption of drugs across the cell membrane. So we can classify these factors under basic heads. One is pharmaceutic factor, another is patient related factor. So pharmaceutic factor, in this a very important factor is physicochemical properties of the drug and excipients. Physicochemical properties includes drug solubility and dissolution rate, particle size and effective surface area, polymorphism and amorphism, pseudomorphism, solvates or hydrates, salt form of the drug, lipophilicity of the drug, pK and pH of the drug, drug stability. Then dosage form characteristics and pharmaceutical ingredients. This includes factors like manufacturing variables, pharmaceutical ingredients, excipients or adjuvants, nature and type of dosage forms, rate of disintegration, disaggregation, and dissolution in case of tablet and capsule, product age and storage conditions. Then patient-related factor in which age and disease condition of the person, GI motility, gastric emptying time, pH and content, intestinal transit time, splanchnic blood flow, pre-systemic metabolism by luminal enzymes, gut walls enzymes, and bacterial and hepatic enzymes. So here, drug solubility and dissolution are important. Particle size and effective surface area is also very important. Most of the absorption takes place in intestine. Why? Because intestine consists of an absorption window. A smaller intestine, you can see that it contains villi and microvilli-like structure, which further increases the surface area of the absorption window. Also, it contains higher density of transporters. So absorption window is any such area where maximum mechanistic supports to facilitate absorptions are present. Then polymorphism and amorphism. Polymorphism is the phenomena where a solute or a substance exists in multiple morphology or in crystal form. Like the shape and size of the crystals may vary or the colors may vary. So generally it is a rule that polymorphism will reduce the absorption of the drug and amorphism will enhance the absorption of the drug. Then polymorphism, where the solute or drug substances accumulates water or other solvent vehicle into them and takes a new form. That is pseudopolymorphism. You can see many chemical exist in the form of anhydrous or dihydrate, trihydrates likewise, or you can see the name of griseofulvin, chloroform, etc. Then salt form of the drug, you can see that most of the drug exist in salt form. It stabilizes these, basically stabilizes the drug. Acidic drugs will bind with the cations, and a basic drug will bind with the anions. So salt forms of the drug like maleate, sodium salt, potassium salt of the drug, likewise, they exist in the salt form. Lipophilicity of the drug, it is an important factor. Lipophilicity supports the absorption of the drug. If the drug is highly lipophilic, then it can cross the blood-brain and other barriers also. PK and pH, we have already discussed. The PK and pH is an important criteria in the case of development, in the case of absorption of the drug. Ionized form of the drug, 50% is possible when pK and pH are equal, and it is important in case of absorption through port transport or passive diffusion. But most of the drugs are passively diffused when they are lipophilic and unionized in nature. Drug stability is important because unstable drug may get bound with some proteins or other substances present within the gut. So drug stability is again an important physicochemical property of the drug. Then dosage form characteristics. Here we take the drug in the form of different dosage forms. I have already told you that drugs are given under different dosage forms: tablet, capsule, then semi-solid syrups, then liquid solutions and all. The dosage forms also affects the absorption. When we design any dosage form, then there are different manufacturing variables depending upon the type of premises, type of instrument, and the process uh, installed or occurred during manufacturing of that. For example, in case of tablet, tablet compacting process can make it much harder, and there it will affect the disintegration of the drug or disaggregation of the drug, and finally the dissolution. As you know that in case of tablet and capsule, three other processes are involved as it is given: disintegration, disaggregation, and dissolution. This will affect the rate of absorption. Then pharmaceutical ingredients uh, or adjuvants may interact among themselves and will affect the drug stability or drug absorption. They will make the absorption poor. Then nature and type of dosage form will also, as you know, as the semi-solid dosage form, then liquid dosage form. As the dosage forms becomes diluted, it becomes more available for absorption. Patient-related factor, age is a factor because in case of infants or neonates, the surface area is less for absorption. In the absorption window, they may also have less developed transport systems in their body. Also, the disease condition may affect the absorption. For example, absorption, if the person is suffering from constipation or diarrhea or some liver problems, kidney problem, then absorption process may get affected. GI motility directly is related with gastric empty time and intestinal transit time. Gastric empty time is the time period where the contents from the stomach gets emptied into the intestine. And intestinal transit time is a time where the contents in the intestine are traveled from small to large intestine and then from large to rectum area for anus rectum area for elimination. So these times are important. For example, if maximum absorption of the drug takes place into the intestine, if intestinal transit time is very low, sometimes in case if gastric motility increases, then intestinal transit time reduces. At that time, the drug may not get sufficient time to get absorbed through the absorption window. So this may affect the bioavailability and further the therapeutic response of the drug. Then pH and contents of GIT are also affecting the drug absorption. Sometimes the contents of GIT may be oily or greasy. In that case, some of the drugs may not get well absorbed, but it becomes supporting when some drugs like which are highly lipophilic, like griseofulmin or lumefantrine, they are if their absorption is supported when the contents of GI are uh, lipophilic. Then perfusion rate or mesenteric blood flow, if it is higher, then absorption is fast. Another factor is pre-systemic metabolism. Metabolism of drugs generally starts when the drug reaches to systemic circulation, that is into blood. But before that, metabolism may get started by luminal enzymes or the gut wall enzymes or some of the bacteria which is present inside the gut and some hepatic enzymes. Metabolism of drugs through these factors can reduce its bioavailability and the drug available for absorption is reduced. So this is the factor very important in case of some of the drugs. Then we will see routes of drug administration. Then we will see routes of drug administration. Through oral route, the drug goes to stomach, then to intestine, then to portal circulation, then systemic circulation. And in case of intravenous or parenteral route, the drugs goes directly to the systemic circulation. So we will compare here. This is a table where different routes are compared among themselves. You can read it later. We will see one by one. Oral ingestion. Absorption from the GIT is governed by factors such as surface area for absorption, blood flow to the site of absorption, the physical state of the drug, whether it is in solution, suspension, or solid dosage form, its water solubility, concentration at the site of absorption. For drugs given in solid form, the rate of dissolution may be the limiting factor in their absorption. We have already discussed this. Since most drug absorption from GIT occurs by passive diffusion, absorption is favored when the drug is in the non-ionized and more lipophilic form. The epithelium of the stomach is lined with a thick mucus layer and its surface area is small. By contrast, the villi of the upper intestine provide an extremely large surface area, approximately 200 meters square. Accordingly, the rate of absorption of a drug from the intestine will be greater than that from the stomach. Gastric emptying is highly variable and influenced by numerous factors. Drugs that are destroyed by gastric secretions or that causes gastric irritation are given through enteric coating. Enteric coating prevents the dissolution of the drug in acidic contents, for example, aspirin. Pharmacologically inactive coatings, often of cellulose polymers, have a threshold of dissolution between 5 and 6 pH. In healthy individuals, gastric emptying is influenced by a variety of factors, including the caloric content of the food, volume, osmolality, temperature, and pH of ingested fluids. Diurnal and inter-individual variations, metabolic state like resting or exercising, and the ambient temperature. Gastric emptying is influenced in women by the effects of estrogen, that is, slower than in men for menopausal women and those taking estrogen replacement therapy. Then controlled release preparations. As you know, a slow rate of dissolution of a drug in GI fluid is the basis for controlled release, extended release, sustained release, and prolonged release preparations. Why they are required? They provide uniform absorption of the drug for 8 hours or longer. Such preparations reduces the frequency of dosaging and they have potential frequency of dosages. I mean, how many times the drug has to be taken, that frequency is reduced. Also, it maintains a therapeutic effect overnight and there is decreased incidence or intensity of both undesired by elimination of the peak in drug concentration and non-therapeutic blood levels of the drug by elimination of trough in concentration that occurs after administration of immediate release dosage forms. Controlled release dosage form, while more expensive way of manufacturing, are most appropriate for drugs with short half-lives, less than 4 hours, where patient non-compliance become a determinant of therapeutic failures. Example in case of depression, epilepsy, ADHD, or treatment with dihydropyrin, which is a calcium entry blocker. But also there are drawbacks of controlled release preparations, like there may be variability in the systemic concentration achieved may be larger in controlled release than for immediate release dosage forms. The dosage form may fail and dose dumping may take place, resulting in toxicity of the drug. The controlled release dosage forms are sometimes developed for drugs with longer T half, more than 12 hours, example, antileptics. The availability of controlled release dosage forms of some drugs can lead to abuse, as in case of oxycodone. Marketed as OxyContin. Then, crushing and snorting the delayed release tablets results in a rapid release of the drug, which enhances absorption and high peak concentrations are achieved. Sublingual administration. This is an alternative route to oral route. Venous drainage from the mouth is to the superior vena cava, which protects highly soluble drugs like isoprenaline, isosorbide dinitrate, nitroglycerin from rapid hepatic first pass metabolism. For example, a tablet nitroglycerin is effective when retained sublingually because it is non-ionic and has very high lipid solubility. Thus, the drug is absorbed very rapidly. Nitroglycerin also is very potent. Absorption of a relatively small amount produces the therapeutic effect, which is unloading of the heart. Ergotamine for migraine in nausea and vomiting patient is also administered through sublingual route. Then rectal administration. Rectal route is less predictable and used when oral injection is not supported by the patient in case if he is unconscious or in vomiting condition. Approximately 50% of the drug that is absorbed from the rectum will bypass the liver. The potential for hepatic first pass metabolism is less than that for oral dose. Furthermore, a major drug metabolism enzyme, which is CYP3A4, is present in the upper intestine but not in the lower intestine. However, selective absorption can be irregular and incomplete, and certain drugs can cause irritation of the rectum. The use of spatial mucoadhesive microspheres may increase the number of medications that can be given by the rectal route. Then transdermal absorption. Absorption of drug via the intact skin is dependent on the surface area over which they are applied and their lipid solubility. The dermis is freely permeable to many solutes. Consequently, systemic absorption of drugs occurs much more readily through inflamed, abraded, burned, or denuded skin. Inflammation and other conditions that increase cutaneous blood flow also enhance absorption. Toxic effects sometimes are produced by absorption through the skin of highly lipid soluble substances. Example, a lipid soluble insecticide in an organic solvent. Absorption through the skin can be enhanced by suspending the drug in oily vehicle and rubbing the resulting preparation into the skin. Sometimes it is called as rubefacient. Because hydrated skin is more permeable than dry skin, the dosage form may be modified or an occlusive dressing may be used to facilitate absorption. Control-release topical patches have become increasingly available, like nicotine for tobacco smoking withdrawal, scopolamine and clonidine for motion sickness and BP, nitroglycerin for angina pectoris, testosterone and estrogen for replacement therapy, whereas estrogens and progestins for birth control and fentanyl for pain relief. Now we will discuss parenteral route. Parenteral routes are all the injections which we through which we take the drug. Intravenous bioavailability is almost complete and very rapid. Or we can give controlled delivery of drug also and can be adjusted to the response of the patient and is achieved with an accuracy and immediately not possible by any other procedure. Irritating solutions can be given only in this manner because the drug, if injected slowly, is greatly diluted by the blood. Occasionally, a drug is injected directly into an artery to localize its effect. Diagnostic agents sometimes are administered by this route. Example, technetium labeled human serum albumin. Unfavorable reactions can occur when high concentrations of a drug or its vehicle are attained rapidly in plasma and tissues. There are therapeutic circumstances where it is advisable to administer a drug by bolus injection, example tissue plasminogen activator, and other circumstances where slower administration of drug is advisable. The factors which influence the rate of absorption for subcutaneous and intramuscular injections are drug concentration, solubility of the drug, local blood flow, area of absorbing capillary membranes, and solubility of the drug in interstitial fluid. Dosage forms can also affect. Absorption usually occurs through simple diffusion to the plasma or lymph or filtration through channels in the endothelial capillary membrane. Subcutaneous injection is uh, uh, is given when the drugs are irritating to the tissue, not given when the drugs are irritating to the tissue. Otherwise, severe pain, necrosis, and tissue sloughing may occur. The rate of absorption following subcutaneous injection of a drug often is sufficiently constant and slow to provide a prolonged effect. Moreover, altering the period over which a drug is absorbed may be varied intentionally, as is accomplished with insulin for injection using particle size, protein complexation, and pH. Absorption of drug implanted under the skin in a solute pellet forms occur slowly over a period of weeks or months. Some hormones like contraceptives are administered effectively in this manner. Intramuscular drugs are absorbed rapidly after intramuscular injection, depending on the rate of blood flow to the injection site and the fat versus muscular composite of the site. This may be modulated to some extent by local heating, massage, or exercise. Generally, the rate of absorption following injection of a aqueous preparation into the deltoid or vastus lateralis is faster than when the injection is made into the gluteus maximus. The rate is particularly slower for females after injection into the gluteus maximus. Slow, constant absorption from the intramuscular site results if the drug is injected in solution, oil, or various other repository or depot vehicles. Intrathecal blood-brain barrier and the blood cerebrospinal fluid barrier (CSF barrier) often preclude or slow the entrance of drugs into the CN. We have already discussed this. Therefore, when local and rapid effects of drugs on the meninges or cerebrospinal axis are desired, as in the spinal anesthesia or treatment of acute CNS infections, drugs sometimes are injected directly into the spinal subarachnoid space. Brain tumors also may be treated by direct intraventricular drug administration. More recent developments include spatial targeting of substances to the brain via receptor-mediated transcytosis and modulation of tight junctions. Pulmonary absorption they do not cause irritation. Gaseous and volatile drugs may be inhaled to trachea and lungs and absorbed by simple diffusion through the pulmonary epithelium and mucous membranes of the respiratory tract. Access to the circulation is rapid by this route because the lungs surface area is large. In addition, solution of drugs can be atomized and the fine droplets in air, aerosols, vapor, and aqueous solution or a suspension is inhaled. Lipid-soluble compounds diffuse more readily. Advantages are the almost instantaneous absorption of a drug into the blood, avoidance of hepatic fast-pass loss, and in the case of pulmonary disease, local application of the drug at the desired site of action is possible. For example, owing to the ability to meter dose and create fine aerosols, drugs can be given in this manner for the treatment of allergic rhinitis or bronchial asthma. Pulmonary absorption is an important route of entry for certain drugs of abuse and of toxic environmental substances of varied composition and physical states. Example, nicotine, volatile anesthetics, and sodium chromoglycate. Both local and systemic reactions to allergens may occur subsequent to inhalation of some of the chemicals. Intra-arterial: occasionally, a drug is injected directly into an artery to localize its effect in a particular organ or tissue, such as in the treatment of liver tumors and head or neck cancers. Diagnostic agents sometimes are administered by this route. Example, technetium labeled human serum. albumin. Intra-arterial injections require a great care and should be reserved for experts. The dampening, first pass, and cleansing effect of the lungs are not available when drugs are given by intra-arterial route. Topical applications on the surfaces, mucous membranes. Drugs are applied to the mucous membrane of the conjunctiva, nasopharynx, oropharynx, vagina, colon, urethra, and urinary bladder, primarily for their local effects. Occasionally, as in the application of synthetic antidiuretic hormones to the nasal mucosa, systemic absorption is the goal. Absorption through mucous membrane occurs readily. In fact, local anesthetics applied for local effect sometimes may be absorbed so rapidly that they produce systemic toxicity. Then I, topical application of ophthalmic drugs are used primarily for their local actions. Systemic absorption that results from drainage through the nasolacrimal canal is usually undesirable because drug is absorbed via drainage is not subject to first pass and intestinal and hepatic metabolism. Unwanted systemic pharmacologic effects may occur when beta adrenergic receptors antagonists or corticosteroids are administered as ophthalmic drugs. Local effects usually require absorption of the drug through the cornea, corneal infection, or trauma, thus may result in more rapid absorption. Ophthalmic delivery system that provide prolonged duration of action, example suspension and ointments, are useful additions to ophthalmic therapy. Ocular inserts, such as the use of pilocarpine containing inserts for the treatment of glaucoma, provide continuous delivery of small amounts of drug. Very little is lost through drainage, hence, systemic side effects are minimized. Novel methods of drug delivery. Novel methods includes directly sending the drug to its site of action. For this, drug diluting stents and other devices are used. The systemic toxicity of potentially important compounds can be decreased by a novel method of drug delivery because the distribution throughout the body does not take place. We can see this through an example. Linkage of the cytotoxic agent calicimycin to an antibody directed to an antigen found on the surface of certain leukemic cells can target the drug to its intended site of action, improving the therapeutic index of calicimycin. Recent advantages in drug delivery include the use of biocompatible polymers, that functional monomers attached in such a way as to permit linkage of drug molecules to the polymer. A drug polymer conjugate can be designed to be a stable, long circulating prodrug by varying the molecular weight of the polymer and the cleavage linkage between the drug and the polymer. The linkage is designed to keep the drug inactive until it is released from the backbone polymer by a disease-specific trigger. Typically, enzyme activity in the targeted tissue that deliver the active drug at or near the site of pathology. Nanoparticles are offering new opportunities for diagnosis, targeting drug delivery, and imaging of the clinical effects. Others, nanoparticles, other microspheres, liposomes, dendrimers. There are so many advanced methods now being developed for drug delivery. Then we understand bioequivalence. What is bioequivalence? Drug products are considered to be pharmaceutical equivalents if they contain the same active ingredient and are identical in strength or concentration, dosage form, and route of administration. Also, the rates and extents of bioavailability of the active ingredients in the two products are not significantly different under suitable conditions. Because of the legitimate concern of clinicians and the financial consequences of FDA-approved generic prescribing versus brand name, this topic will continue to be actively addressed. So, bioequivalence provides a way where the patented branded drugs in a cheaper way can be provided to the global market after the patent expires. Now, what is bioavailability? Bioavailability indicates the fractional extent to which a dose of drug reaches its site of action, taking into account, for example, the effects of hepatic metabolism and biliary excretion that may occur before a drug taken orally enters the systemic circulation. Bioavailability will contain a fraction or amount of the drug that ultimately reaches to the site of action after all the hurdles in its way, like binding with the proteins or some other cellular components or loss of drug through first pass metabolism or any other pre-systemic and systemic metabolism pathways. So how we calculate bioavailability? Uh, F is the fraction, F is the bioavailability, which is the fraction of dose which reaches to the site of action. So bioavailability multiplied by dosing rates is equals to clearance multiplied by steady state concentration, where the value of F is between 0 and 1. The value of F varies for drugs administered by mouth, and successful therapy can still be achieved for some drugs with F value as low as 0.03, for example, etidronate. Graphically also bioavailability can be plotted where you can see yellow curve, it is area under curve where drug is administered through oral route, and this light yellow, it is area under curve when drug is injected through uh, parenteral route. Then you can see there is a difference between the size or area covered under these curves, and this difference is bioavailability. So bioavailability is the ratio of area under curve for oral dosage form and area under curve for injected dosage form multiplied by 100. Knowledge of drugs that undergo significant metabolism or require active transport across the intestine and hepatic membranes instructs our understanding of adverse events in therapeutics. Since some drugs are substrates for the same drug metabolizing enzyme or drug transporters and thus compete for metabolism and transport. Choice of the route of drug administration must be based on an understanding of the mentioned conditions. Then, what are the different factors affecting bioavailability? All the factors which affected absorption of the drug will also affect the bioavailability, like intestinal motility, drug interactions, content or type of food in the GIT, molecular weight of the drug, types of formulations, dosage forms, like it is solution, suspension, capsule, or tablet. Then, solubility of the drug, chemical instability of the drug in gastric pH. For example, penicillin and insulin, they are unstable in the gastric pH or acidic pH. Then first pass metabolism reduces bioavailability, heat, exercise, and perfusion rate for subcutaneous and intramuscular bioavailability are important. Then abrasion on the surface to enhance topical bioavailability. Then we will study the concept of prodrugs. You can see this in this table. Prodrug will contain a complex type of name like dipivalyl adrenaline for adrenaline, ibuterol for terbutaline, indanyl carbenicillin for carbenicillin, pivampicillin, talampicillin are prodrugs for ampicillin, then prazipam for desmethyldiazepam, and clorazipate for desmethyldiazepam. So prodrug is an approach to enhance the bioavailability of the drug. When the drugs get inactivated in the GIT, then it is important to protect this so that lump sum or the desired amount of drug reaches to the site of action. So antric coating is one approach, and designing the drug in the form of prodrug is another approach. So in the case of prodrug, the drug is chemically modified to improve bioavailability, where active drug is liberated after absorption or after metabolism. The liver will convert prodrug into active drug. First pass metabolism As you saw, for first pass, what is first pass metabolism? First pass metabolism is the intestinal and hepatic degradation or alteration of the drug or substance taken by mouth after absorption, removing some of the active substances from the blood before it enters the general circulation. First pass metabolism, as you know, it reduces bioavailability. So you can see what is first pass metabolism. Venous system, it transports blood from nose directly to the heart. No liver metabolism. Liver, 90% of oral medications metabolized and destroyed by the liver before it gets to the heart. Portal circulation, all the blood from the intestine is taken to the liver for detoxification. Then nasal absorbs directly into the veins. Heart pumps blood out to the entire body, no delay. Oral administration sit in the stomach and for 30 to 45 minutes. So through this diagram, we can understand. Then portal circulation delays and other ways like venous, nasal, hearts, and other routes of drug administration. They are having less time to send the drug directly into the distribution, directly for the distribution into the systemic circulation. So that's for this time. Pharmacokinetic is an important aspect where we study the metabolism, elimination, distribution, and absorption. It starts from ingesting the drug either through oral route or through sublingual, subcutaneous, or through any other injections or transdermal route. And after the drug is absorbed, it goes to the systemic circulation for distribution, and we will study distribution in the later slides. So, for understanding the concepts better and in a detailed way, you can refer to these books: Essentials of Pharmacology, K.D. Tripathi, Goodman Gilman's Pharmacological Basis of Therapeutics, Lippincott, Karlsrung and Vetram, Clinical Pharmacology by Bennett and Brown. There are so many reference books, good reference books to undergo depth understanding of this topic. So here I stop. Thank you all very much.